Hi, my name is Konikoclanis and you're watching the video Fourth Cranial Nerve Palsy, Characteristics of a Bilateral Palsy. Now, bilateral fourth nerve palsy is relatively common, so you need to be aware of the distinction between a unilateral palsy and that of a bilateral palsy. This video will therefore be focusing on the features of a bilateral fourth nerve palsy, regardless of whether it is congenital or acquired. You now have the tools from your previous videos to distinguish the congenital from the acquired fourth nerve palsy, or the long-standing versus the recently acquired fourth nerve palsy. This video will now add to this by teaching you how to distinguish a bilateral palsy from a unilateral palsy, regardless of whether the patient has something congenital or acquired. Okay, so with bilateral fourth nerve palsies, we expect to see a hyperdeviation or a hypertropia. It could be a hyperphoria as well, that's often smaller than expected. The reason we see this is because there's a counterbalancing between the two eyes that are affected. So let's think about this. If you have a right superior oblique palsy, you're expecting a right on left, a right hypertropia. If you have a left superior oblique palsy, you're expecting a left hypertropia. Now, even though you have a left and a right superior oblique palsy and a bilateral superior oblique, one eye needs to fix. So when the patient is fixing, they'll choose to fix either with the left or the right. Let's assume the patient fixes with the left for a moment. That eye was destined to be hyperdeviated. Now, it's got to come down to take up fixation. And with it, the right eye will come down. Remember, we make conjugate eye movements. So that right hyperdeviation will be smaller than what we would expect it to be, because the patient is fixing with a paretic eye, driving the right eye down. So if you see significant underactions or overactions that don't quite match what you would expect to see in primary position in terms of the deviation, then this is an indicator that you're likely to have a bilateral fourth nerve palsy. Let's look at the patient over here to the right. If we look at them in primary position, it's very difficult to see whether there is a deviation there. But if we move over to right gaze, we can see a significant left on right. And then up here we can see the inferior oblique overacting, and down here we can see the superior oblique underacting. And the same is happening on this side. We can see the inferior oblique up here overacting and the superior oblique underacting here. So we should expect to see a larger deviation in primary, given the distinct under and overactions in this particular instance. So this is one of those classic signs of a bilateral fourth nerve. The other thing is that you will see reversal of height in lateral gaze. So coming back to this patient, when the patient looks over in right gaze, we have a left on right, but when we take the patient over to left gaze, we have a right on left. This is reversal of height in lateral gaze. Now, I've mentioned in previous videos in terms of principles of distinguishing a mechanical versus a neurogenic palsy, that mechanicals are the deviations that tend to have reversal of height. The bilateral fourth nerve palsy is the exception here, where it's neurogenic, but reversal of height occurs because you have a bilateral fourth nerve palsy that's driving reversal of height. So in this position here, it's the inferior oblique over and the superior oblique under of the left eye that's causing this left on right. And when you move over to this position of gaze, we've now got the right inferior oblique and the right superior oblique driving the right on left. So again, here is an exception to the rule where a reversal of height in this instance is an indicator of bilateral fourth, not of a mechanical restriction. The other thing noted in these patients is generally you'll notice a V pattern with an esotropia in down gaze most commonly, and the V pattern can be very significant in the bilateral patient. In the unilateral patient, it tends to be only slight, or it may not be there at all. In the case study here that we have to the right, it's not clear whether there is a V pattern. We'd need to actually measure the deviation up and down gaze to compare. I want to bring your attention back to the reversal of height. In this particular patient, the reversal of height is very distinct. The over and under actions are relatively obvious in this photograph, and the reversal of height, the left on right in right gaze and right on left in left gaze, is fairly easily distinguished in the photograph. However, for some patients, the clinical signs are a little less obvious, and I want to show you an example of that. Here we have a patient who has actually been diagnosed with a bilateral fourth nerve palsy, but the clinical signs are more subtle. The patient's over and under actions are more milder, and therefore the reversal of height is more subtle. Despite this, we also see a difference with the V pattern. This patient actually has a distinguishable V pattern in the photograph. Let's take a closer look. Let's start off in primary position. Here, it's difficult to say whether there is a hyperdeviation. We would need a cover test. And this is as expected with the bilateral fourth nerves. Generally, we see or often see small deviations in primary. If we look over to the right, we have a left on right. It's relatively subtle and it's more obvious, or the height is more obvious in left gaze, where we have the right on left, and here we have the reversal of height. Let's have a look at ocular movements, and up here we can see that there is an inferior oblique overaction, and down here it appears we have a superior oblique under, which is what's driving this left on right, the right on left. And then if we move over here, the inferior oblique overaction here is subtle. I'm not sure that it's there. We need a cover test. But if we look down here, it seems like we have a more obvious superior oblique underaction in this particular instance. So in this instance, the right on left in left gaze appears to be greater than the left on right in right gaze. The right superior oblique palsy is greater than the left superior oblique palsy. And just quickly looking at alphabet patterns, we can see here the difference between up gaze and down gaze. We have a V pattern. Lastly, in relation to mapping their ocular movements, these patients give very typical Hess fields. They have what's called the tipping of the visual fields. Now, what you can see here is the two fields seem to be tipping outwards. What's causing this is the superior oblique under here and the superior oblique under here. Now, we have an asymmetric bilateral fourth nerve here where the left superior oblique underaction or palsy is greater than the right superior oblique. But you can see that those superior oblique unders and then the subsequent muscle sequelae is starting to tip those visual fields outwards. Now let's move on to a couple more features that distinguish a bilateral from a unilateral. In terms of the abnormal head posture, the unilateral fourth nerve generally has a tilt, or they'll adopt a tilt as part of their abnormal head posture. However, with bilateral fourth nerves, it's more typical to see a patient utilise a chin down position rather than a tilt right or tilt left. And the reason that they do this is generally they won't actually have BSV tilting right or tilting left. However, bear in mind that they may have a tilt if the palsies are asymmetrical and there is one of the eyes is fairly mild in terms of the oblique palsy. Okay, so the expectation is that given that you have a bilateral superior oblique palsy, you actually should have a positive Bilchowski head tilt test response on either tilt. If we move over to the right here, we don't have the primary position deviation, but we've actually had an increase in height on tilt right and tilt left, and we also see a reversal in the height here as well. So here we see a right on left, and here we see a left on right. Okay, and finally torsion. Torsion is actually a good indicator that you have a bilateral fourth nerve versus a unilateral. Generally, unilateral fourth nerves will have somewhere around or up to 5 degrees of excyclotropia. A bilateral patient usually has 10 degrees or more. So 10 degrees of excyclotropia is a good indicator that you have bilateral fourth nerve palsy. The other thing is that because the superior obliques are underacting and are utilised mostly in down gaze, you usually see a significant increase from the primary position excyclotropia and the down gaze excyclotropia. So this is where it's really useful to measure excyclotropia in both primary and down gaze if you suspect a bilateral fourth nerve palsy. And finally, I need to bring your attention to the masked bilateral superior oblique palsy. You need to be aware that some patients, when they have asymmetrical superior oblique palsies, that what can happen is that asymmetry can mask one of the superior oblique palsies. So let's say, for instance, that we have a right superior oblique palsy and a left superior oblique, and the right superior oblique palsy is relatively large, but the left is very mild. You can miss the left superior oblique palsy and end up diagnosing the patient as having simply a unilateral right superior oblique palsy. Generally, these are going to be difficult to see on ocular movements. So when you're assessing ocular movements, it's going to be difficult to see the reversal of height. It's going to be difficult to distinguish whether there is a positive Bilchowski head tilt test on tilt right and tilt left. So you'll be questioning whether there is a bilateral superior oblique palsy. So the golden rule is always assume a bilateral fourth nerve palsy until proven otherwise. You should particularly assume that you have a bilateral superior oblique palsy where you have a patient who's had trauma. Now, some patients are going to be very, very difficult to make the distinction and to work out if they are indeed bilateral. The time that you will see that it was a bilateral and that you incorrectly diagnosed it as a unilateral is post-operatively. If they've got a bilateral superior oblique palsy and say, for instance, the right is the one that's noticeable and the left has been masked, if the surgeon operates for the right superior oblique palsy post-operatively, the left superior oblique will be unmasked and you'll notice it. So it's wise in these instances to warn your patients that it's possible that the other eye is affected, that's not being operated on, and that surgery may unmask the second superior oblique palsy, in which case further surgery may be required if the patient doesn't have comfortable BSV post-operatively. Okay, so in summary, here we have a table that gives you the key clinical investigations that will distinguish a unilateral from a bilateral palsy. So remember, for a bilateral, the hyperdeviation can be a lot smaller than expected given the under-over actions that you're noticing on ocular movements. A bilateral fourth nerve palsy more often has a V pattern with an ESO in down gaze, and these can be relatively large V patterns. Look for reversal of height on lateral gaze and look for a positive Bilchowski head tilt test on both right and left tilt. Remember to look at your excyclotropia, measure the excyclotropia, and if you've got excyclotropia of 10 degrees or more, this is highly suggestive or highly diagnostic of a bilateral fourth nerve palsy. Also look for that significant increase in down gaze. And finally, check the abnormal head posture and see whether they're tilting right or left. They generally, or bilaterals will generally have a chin down position, but remember, if you have a bilateral fourth nerve palsy that's asymmetrical and one of the palsies is very mild in nature, it may be difficult to differentiate between the unilateral and bilateral, and in this instance you'll have what's considered a masked bilateral superior oblique palsy that's likely to only be unmasked when the patient is operated on. Okay, that brings us to the conclusion of this video. Thank you for watching.